Is there any questions from anything we covered last time? I'm very disappointed no one has like the onesie on with like the little butt flap as far as their pajamas go. That was pretty close. Okay, that's pretty good. Like the chicken soup. I was barred from participating in Pajama Day, which I still think is kind of BS because I was dropped of those indecent exposure charges. So whatever. Whatever. Anyway, so we're going to finish up. We're going to round out this section talking about the autonomic nervous system. My alternative joke to Pajama Day, someone says, why aren't you participating in Pajama Day? And I say, this is my pajamas. I believe in dressing for excellence at all times. But anyway, all right. So we've talked a lot about the autonomic nervous system throughout kind of all the other organ systems here. Here's what we're going to discuss a little bit more formally. Obviously, we know this can be broken up into two major sections, which are sympathetic and parasympathetic. Absolutely, we know a lot about these. We're going to just kind of go over kind of the functions of it, kind of the organization, and then kind of briefly go through some tables that kind of talk about the actual functions. This is where we kind of bring everything together and try to remember these different functions. So that way, if I ask you on a test, hey, if I alter this part of the system, what effects might you expect to see from a physiologic standpoint, right? So we're going to kind of looking like body system wise instead of just looking at, say, individual organ systems. So instead of, say, just asking about like in the urinary section, like what are the effects of the parasympathetic nervous system, you have to be able to say more kind of globally, what would you expect if you had, say, some sort of alteration, either metabolism of neurotransmitters, if you had, say, a blockage of reuptake, if you had any number of things. We'll kind of cover those examples here in just a few minutes, and then we'll have the review afterwards, and so we'll kind of you'll get some better ideas of what type of questions I like to ask in those circumstances. So anyhow. Right, so looking at the anatomy here of the sympathetic nervous system, kind of see how you have these nerves kind of coming off of the spinal cord here, and you're going to have these sympathetic ganglion that are going to be kind of located on either side of the spinal cord there, and there's going to be a lot of synapsing here. This is where you have those synaptic junctions for the most part, where we talked about preganglionic and postganglionic fibers, right? And we were saying with the sympathetic nervous system, where does acetylcholine come into play? All the preganglionic fibers, right? So again, all of these preganglionic nerves you're going to find here are typically releasing acetylcholine, which sounds kind of counterintuitive because when you think acetylcholine, you think parasympathetic. But remember, we have different types of acetylcholine receptors that are available, right? So not only do we have the muscarinic, but we also have the nicotinic, right? And so this is where a lot of these preganglionic fibers are going to be synapsing on. Are going to be these nicotinic receptors. This is where they're releasing acetylcholine. Now again, we're going to find some examples where there's sort of like direct innervation with some of these preganglionic fibers, but this is the kind of the general flow of things. You can kind of see here from these ganglion how they're going to be going through and kind of innervating different organs here, and we're going to look at the different effects. So that way, if you have someone, say for instance, who is in a very sympathetic sort of state, right, someone who, say, is overloading their sympathetic nervous system, you can just look at a patient, you can look at their signs and symptoms and kind of figure out, okay, this looks like someone who has having overdrive of the system, right? So again, when a patient comes in, they've overdosed on cocaine or something, like I know what a cocaine-looking patient looks like because their sympathetic nervous system is a 10 right now, right? And so we'll talk about tone of the systems here in a little bit as well, but we'll kind of cover those signs and symptoms a little bit later. Anywho, so looking at the different ways that these nerves can synapse, and again, typically you're going to have in this sort of ventral root here from the spinal cord, we're going to have these fibers that are going to be coming out. This is going to be the preganglionic fibers, these neurons here. So you can see the table here. So preganglionic, the black ones are going to be the postganglionic neurons, and then we'll also have some sensory neurons. These are important as well because these are going to be detecting things like, okay, well, how much, vasoconstriction am I having, or how much, gut motility is there, and things like that, and that can feed that system, that information back in, either up to the CNS, or it can kind of, have some reflex arcs are going to be here as well. So anyway, so again, we're going to have basically three pathways. As soon as these preganglionic neurons are leaving the spinal cord here, you can find they can either synapse with postganglionic sympathetic fibers right there in the ganglion, so they can synapse right here and then travel out and innervate whatever organ it happens to be, whether it be, say, the detrusor muscle, or whether it be, the eyes, whatever it happens to be. You're going to find some cases where it's going to be able to pass kind of upward or downward the chain. So when I say the chain here, we're just talking about these ganglionic chains here located on either side of the spinal cord. Or in some cases, it may actually pass through and then actually synapse with a peripheral ganglion. You can see this happening here, where you'll see the nerve fiber come in, and then it can then travel through, and there can be a peripheral ganglion. And if you look back at that picture, and I'll show it again, you're going to see there's peripheral ganglions are good for kind of communicating with kind of whole organ systems. So for instance, like the GI tract gets one of these peripheral ganglions, etc. Here's a good picture of looking at the peripheral sort of ganglions. So you can see how they're innervating different, kind of more large sets of organs here, namely things like the GI tract, etc. Some of these postganglionic fibers are going to pass from the sympathetic chain. They're going to pass, go through these the gray rami of the spinal nerves, and this is where they can actually directly innervate things like blood vessels, sweat glands, piloerector muscles. So these are things like, if you think about someone who is in a sympathetic sort of state, are they typically pretty dry, or are they more diaphoretic? Typically think of diaphoretic, right? So if I called one of you to come up here and give the rest of this lecture, I'd imagine your sympathetic nervous system would be starting to go pretty hard there, and you probably be sweating buckets, right? So that's one of those things where you can actually have some of these more direct innervations. You can see here these fibers that will come up and they can travel and kind of directly innervate things like, the piloerector muscles, the blood vessels, things like that, to help kind of directly control that. In some cases, things like the sweat glands, typically when you think like parasympathetic nervous system, you think a lot of like secretions and things like that, but with the sympathetic nervous system, you definitely see sweating and whatnot, and so they can actually have some innervation of muscarinic receptors there. We'll show that example in just a few minutes, but this is one sort of innervation we can see there. You're also going to find that you can have some sympathetic nerve endings that will go directly to the adrenal medulla there, and so again, you can find that this isn't actually releasing things like norepi onto the adrenal gland, but it's going to be another nicotinic synapse that's going to be there. Acetylcholine is going to be affecting those nicotinic receptors, and that will actually directly stimulate the adrenal gland to secrete things like epi and norepi, right? And again, which one's a little bit faster, the adrenal gland in activating the sympathetic nervous system, or say the sympathetic nervous system itself, as far as like causing physiologic changes? Yeah, the actual sympathetic nervous system is a lot faster than you see with the adrenal gland. Adrenal glands are going to be better for more kind of long-term sort of increases in those hormones, right? And again, with the sympathetic nervous system, the main neurotransmitter we're looking at is norepi, right? Versus in the adrenal gland, what are we predominantly releasing? It's going to be a little bit more epi, right? So you're going to find that makes sense, because actually norepi is going to be one of those steps along the pathway to actually forming epinephrine, right? So norepi can actually be formed into epinephrine. We'll see that more in just a second here. Yes, sir. Yeah, so say for instance I called on you to come up here, give the rest of the lecture, right? So that would be an immediate like, hey, holy crap, fight or flight sort of response there, right? So again, that would be the sympathetic nervous system here. This would be direct innervation of those organs, saying, hey, we're stressed right now, right? We need to react to this. That is the sympathetic nervous system itself, versus some of that stimulation there is also going to stimulate the adrenal medulla there, but you're going to find that's going to be better for more kind of long-term sort of stress, right? That's going to be better for long-term sort of reactions there, because again, that has to be released into the bloodstream, that has to circulate around before it has its effects, versus if I have a direct innervation of the organ, that's almost instantaneous, right? So as fast as I can send that action potential to the organ and release that norepinephrine, those changes are going to be almost instantaneous, right? Versus more kind of like an endocrine site like signaling, which you'd have with epinephrine sort of circulating in the bloodstream. Yes, ma'am.
So just to get it right, like both the sympathetic and the parasympathetic, it releases acetylcholine at the ganglions, and then at the actual target site, it releases like parasympathetic will release like acetylcholine, and sympathetic will release norepi.
Yes, that is for the large majority correct. So the preganglionic fibers are going to be acetylcholine onto nicotinic receptors. For postganglionic fibers, that's what's going to be changing, and so for the sympathetic, it's going to mainly be norepi. For the parasympathetic, it's mainly going to be acetylcholine onto what type of receptor? Muscarinic, right? So again, we'll look at some more, another picture that kind of delineates that a little bit more a little bit later on. But again, just trying to go over the kind of the basic organization here of the sympathetic nervous system. Okay. And again, adrenal medulla is going to be releasing epi and norepi, but predominantly it's going to be more, probably like 80% epi and like 20% norepi. Again, we'll look at why that matters in a little bit later, just as to its kind of intrinsic sort of receptor effects in a little bit here, right? Okay. Flipping over and looking at the anatomy of the parasympathetic nervous system, you don't really see those nice kind of organized ganglion here like you would see with the sympathetic nervous system. Mainly, you're going to have a lot of these signals are going to be transmitting through some of the cranial nerves, like 3, we're going to have 7, 9, but 10 is obviously the biggest one. About 75% of those signals carried through 10, because that is our vagus nerve, and we vagal down, we're trying to activate our parasympathetic nervous system, things like that. And so you can see here we're going to have sort of this portion, it's going to be kind of innervating sort of like the upper areas of the body, you can kind of say, and then you'll have the sort of the sacral areas here, they're going to be innervating sort of the lower organs, right? So think about your urinary tract, lower portions of the GI tract, etc. And again, in some cases, you may actually find some of these preganglionic fibers may travel uninterrupted into actually synapsing with the organ wall itself. So instead of having, say, for instance, a ganglion that is pretty proximal to where the actual coming out of the spinal cord itself, here you're going to find that these preganglionic fibers are traveling for longer, usually to the organ itself, before it synapses and then actually innervates, actually stimulates the muscarinic receptors. I'll show you a picture of what that looks like in just a few seconds here. Okay, and so here's a good example of that. So again, looking at the parasympathetic nerve fibers, notice here that it'll leave the cranial and spinal nerves. It'll travel along, so it's going to travel basically all the way to the organ itself, and then release acetylcholine onto the nicotinic receptors. Whenever you see an N there, that is nicotinic. And then the ganglion will then release acetylcholine onto muscarinic receptors. Okay, versus when you have the sympathetic fibers here, you're going to be seeing that they will travel from thoracic and lumbar spinal areas onto these ganglion, which are again pretty proximal to the spinal cord itself. And then you have those neurons traveling over to the actual target organs. Why we're organized that way, I have no idea what benefit that provides for one system or another. Who knows? But that's just the way it is, right? And again, just remember, sometimes you're going to have direct innervation. This is a good example where you have the adrenal medulla actually being hit by those preganglionic fibers. And so you see acetylcholine being released on those nicotinic receptors, but that ultimately stimulates release of epi and norepi into the bloodstream, right? Okay, and again, this is kind of just showing you what that is. Again, most postganglionic fibers typically are going to be either touching or going to be passing by the affected tissues, and so that's how they're going to have their innervation there, right? Okay. So looking at the biosynthesis, we talked about this a little bit already. Obviously, acetylcholine is made from acetyl-CoA and choline, right there in the name. I had the guy who taught me pathophysiology in pharmacy school. He said, "You say acetyl-CoA, you're saying it wrong. It's acetylcholine, is how you say it, or acetyl-CoA." And so he always like to emphasize that a lot. So if you say acetylcholine, that's totally fine. I'm going to say acetylcholine the rest of my life because I don't want to sound silly. But anyway, that was just what he said. Anyway, the enzyme responsible for this is choline acetyltransferase. You don't see too many things that actually affect the biosynthesis of acetylcholine too drastically here. More often than not, you're going to run into issues where you have the breakdown being affected, right? So we said the acetylcholine will be broken down. And again, this is important because if you don't have breakdown of these neurotransmitters, what can happen? You're going to have overstimulation of these synapses, right? So you got to have the breakdown of this, otherwise you're going to have overstimulation of either of these systems here. We're going to look at some of those effects a little bit later on. But the acetylcholinesterase is the most important enzyme for metabolizing acetylcholine, and you're going to find that this is good because this will allow us to recycle choline and allows us to kind of establish normal transmission. You can do things like, say, for instance, have too little acetylcholinesterase, right? And that's going to lead to too much acetylcholine. And you're going to see it's going to have pretty dramatic effects, right? And so we're going to look at some examples of that a little bit later on. But kind of keep that in the back of your mind that that's the main enzyme to break down acetylcholine. On the flip side, if we're looking at the sympathetic nervous system, obviously we mentioned the tyrosine coming in from the diet. The diet is really important for helping to develop things like dopamine and eventually things like epinephrine and norepi. But typically, when you're producing the norepinephrine, you're going to find tyrosine is going to L-dopa to eventually form dopamine to eventually form norepi, right? In some neurons, you're going to find that it's going to just stop at dopamine. Doesn't necessarily need to make a whole lot of norepi. So think about like the neurons in the substantia nigra when you're thinking about the basal ganglia, right? What is the basal ganglia good for?
Large automatic control, so it's muscle tone.
Some muscle tone, but you're going to find like there's kind of complicated movement sets, right? So again, when you think about things like having good gait and actually the more complex movement patterns like writing, things like that, like that's going to be with the basal ganglia, right? We're going to talk about where you find more kind of coarse motor control versus more detail, but the basal ganglia is pretty complicated. It's pretty good at helping with more complicated sort of movement sets. Yes, sir.
So if you had a lesion of the basal ganglia,
so this is a loaded question.
Yeah. So why would you have like bradykinesia? Because what we read was that it's like more coarse movements, like walking.
Sure.
Yeah.
Yeah. So the basal ganglia is super complicated. If you go back and you look at those diagrams where we talked about how dopamine affects that system, because again, you have things like substantia nigra, you have the globus pallidus, you have all these different sets here, and the question is, okay, well, is it going to be stimulatory or inhibitory? And actually depends based on which receptors are getting hit. Dopamine in some cases can have a more stimulatory sort of effect, and in other cases it can have more of an inhibitory sort of effect, depending on the receptors you're actually activating. And so what you find is, if you had a lesion, say for instance you have someone who had a stroke, or maybe for instance someone is having destruction of those neurons, say with with Parkinson's, right? You're losing that dopamine. You end up finding that the thalamus ends up getting hit with a very strong inhibitory sort of signal. So you get bradykinesia because they have a hard time initiating movements because they have such a strong inhibitory sort of system there, right? However, if I were to restore that dopamine function, say for instance I give them a precursor like levodopa or L-dopa, I were to give that to them and then they can convert it over into dopamine, then you would find that actually have a more stimulatory effect overall on the thalamus, and you can actually initiate movements in those cases there, right? So bradykinesia is definitely one of the big things you're going to see with that. And in fact, as you have more progressive cases of things like Parkinson's, they develop what we call catatonia, where basically they have no movement whatsoever. Basically, they're just kind of locked inside their own body. The mind may still be there, may still be functioning to some degree, but they can't actually initiate any movements, right? So that's one of the big things you end up seeing with that. They kind of jive with what you guys learned.
Why would they have increased reflexes?
It would have to do with those sort of inhibitory and excitatory signals that are getting kind of dysregulated, right? So, and again, it gets complicated. So basically, like, you're going to find that things like, by having too much inhibition of a GABA neuron, seeing overexcitation, right? Or by having, say, for instance, under excitation of a glutamate neuron, that also causes inhibition. So again, it gets more complicated than that, but the bradykinesia is one of those big things you end up seeing with damage there, right? And in fact, and again, I always bring it back to drugs because I like drugs. Knowing about them, not doing them. But one of the big things you see is actually that with antipsychotics, right? Antipsychotics as a class generally block dopamine transmission. They will block D2 receptors. And actually what you can actually do is instill a Parkinson's-like syndrome for those patients. If you have something that really blocks strongly the dopamine neuron, it's like they have Parkinson's. And so you see a lot of those side effects. We call it extrapyramidal side effects. Remember, extrapyramidal just means all those motor neurons are lying outside of that pyramidal tract, right? And so you end up seeing a Parkinson's-like syndrome. So that's one of those things you can see there. Actually, a really kind of cool sort of side story, not to go off too much on a tangent here, but because it relates back to dopamine, we're going to talk about dopamine here. There's actually a period of time where people were trying to design their own drugs, right? So you have these like street chemists who are trying to design, man, I want to make the next heroin, I want to make the next cocaine or whatever it happens to be. And I don't know if you guys, how many took organic chemistry? How often did good, I'm glad everyone didn't skip past the prereqs or anything, but how often did your experiments like go perfect, 100%, something you feel really, really confident in, this is 100% yield for this product? If you may be a little bit overconfident, I would venture to say I was terrible at organic chemistry lab. I knew all the reactions and everything. I ended up having like sweet talk my professor to come in and actually do the work for me, which I do not recommend you guys doing. But so I would not definitely trust these street chemists who are working with and usually in their kitchens and things like that. But anyway, so there's this guy who actually ended up developing. He was trying to make a designer form of meperidine. Meperidine or Demerol is a type of opiate, and so he made his own version of it. And what's interesting is it actually produced a byproduct that basically just destroyed all of his dopaminergic neurons. So basically, he gave himself Parkinson's when he took this drug. So when they actually found him, when EMS arrived to his home, I guess they're doing a well check or something, they actually find he's in this like catatonic state, like he had Parkinson's, like a relatively young guy, right, who has no history. It's very odd. So once they actually did the investigation, they found, oh wow, this drug actually just burned out all of your dopamine neurons. And so what they're actually able to do is to take that product and use it in things like animal models, and actually gave us the ability to induce Parkinson's in animals. That way we can now do research on it. And so there's a lot of development of new therapies and new ideas about how Parkinson's works by this guy basically giving himself the disease. So anyway, a little interesting kind of medical stories you can find out there. Anywho. But that's one of the pathways here, right? So dopamine eventually gets converted over to norepi, and then we're going to find in the adrenal gland, that's where you can convert norepi over into epinephrine itself. Now remember that in a lot of cases we're going to have things like reuptake into the presynaptic neuron. This is good because it's efficient. It helps us to recycle those neurotransmitters, right? And so what would happen, say for instance, if I blocked reuptake of say norepinephrine? What would happen to the levels of norepinephrine in that synapse? It would increase, right? And what do you think would happen to sympathetic tone? Talk about tone a little bit later, but basically it's kind of like the overall level of stimulation of that nervous system, right? Because again, it's never that you're going to be in a state where you have zero output from sympathetic and parasympathetic. There's always going to be kind of a balance there. If you had more norepinephrine in the synapse, you're probably going to have more of that norepinephrine interacting with the receptors. You're probably going to find an increased sympathetic activity, right? Okay, so these are kind of the stepwise approaches you need to think about these things when we're saying, okay, if we alter this system, what are effects are you going to expect to see? So by increasing levels of norepinephrine, it's typically going to increase sympathetic effects, right? Makes sense. You can do that by either blocking the reuptake, or what's the other way I could do that? I could stimulate more release of it. That's another way I could do that. And in fact, some drugs will do that, things like amphetamines. What else could I do?
Decrease metabolism.
Perfect. Yes, I can decrease the metabolism, right? So I can do things like block catecholaminomethyltransferase, or in cases I can block monoamine oxidase. Either of these would actually increase levels of the neurotransmitter, and then I can then see increased activity as well, right? So again, this is the main basis. And if you remember, we were talking about serotonin a couple lectures ago. You remember this also got metabolized by monoamine oxidase, and again, that was the basis for our treatment for depression for a good long time, for several decades, until we found sort of better and safer medications. But again, so this is the main pathway. So again, if I blocked activity as a catecholaminomethyltransferase, you'd also expect norepinephrine levels to increase because I'm blocking metabolism, and thus I would expect increased sympathetic effects. Okay. So let's look at the receptor effects more specifically. We've been alluding to these all semester long, but again, just more formally, we'll talk about them here. Now, again, depending on whether you see excitation or inhibition is going to entirely depend on the tissue type, just like we saw with other hormones, say, for instance, like, estrogen, right? Estrogen receptors, it acts very differently in the breast tissue than it does in, say, for instance, the uterine tissue, right? It can have very different effects there, or say, for instance, in the bone. Same thing applies here, right? Where depending on the tissue, right, you may find these effects to either be stimulatory or inhibitory. And so you can find that either the receptors themselves are going to be basic ion channels, which typically will open up and either allow in for, say, negative ions to flow in, or for positive ions to flow in, depending on what you're dealing with. Or there could be more of these metabotropic receptors. And when I say that, it's basically referring back to things like G protein coupled receptors, etc. Right? So again, when you have like an ion channel open up, maybe you have calcium flow in, maybe you have potassium leave. It just depends on kind of what tissue you're dealing with and what's going to happen there. Versus the G proteins, typically you're going to see either stimulation or inhibition of, say, things like cyclic AMP, which was the enzyme that formed that. The adenylyl cyclase, good. And then we have also cyclic GMP, which is formed by the enzyme. And guanylyl cyclase, good. So looking at the cholinergic receptors, again, the main types we have here are nicotinic and muscarinic. So anyone know what plant this is? The plant itself is not a mushroom. No. So this is actually the nicotine. So this is the tobacco plant. This is where we get our nicotine from, for the most part, right? And then anyone know what kind of mushroom this is? The magic, it's actually not a magic one. It's a type of, I guess you could say, you get some magic effects from it. And we know what video game this is made famous in? Mario. Interesting. Mario takes a mushroom and all of a sudden he grows larger and he sees all these things walking around coming at him. And he's interesting. They have a whole new take on Mario. This is actually the Amanita muscaria, or the fly agaric is another name for it. This is this is where we found the first sort of product that actually can interact with these muscarinic receptors, called muscarine, which makes sense where we actually got the idea for naming it the muscarinic receptor. So we know exactly what stimulates it there in this case. Do you have a question in the back? All right, answer. Okay. So anyway, so typically with nicotinic channels, you're going to find these typically are going to be ligand-gated ion channels. This kind of makes sense when you think back to muscular function. Remember when you have acetylcholine interacting with those nicotinic receptors there, what type of channels open up? Sodium channels, right? So again, same thing's happening with these nicotinic receptors basically all throughout the body. Typically, there's going to be ion-gated channels, or ligand-gated ion channels. It just means you need to have acetylcholine interact with the receptor, then that's going to open up the ion channels to allow something to flow in or out, depending on what type of receptor channel it actually is. On the muscarinic side, these are always going to be G proteins you're linking to. And again, I'm not going to get specific into is it GS, GQ, GI, because again, there's no point in memorizing that for our purposes. Just know that typically muscarinic is going to be G protein related here. Okay. Now on the flip side, we're going to have our adrenergic receptors. And so when we get into the actual tables and we're talking about the different effects here, the thing I will have you note for memorization purposes or purposes of knowing for the test, know the differences in effects between nicotinic versus muscarinic. I'm not going to ask you the difference between the M1, M2, or M3 receptor. That's not really our place to know that at this point. However, when we get into the adrenergic effects, right, the catecholamine effects of epinephrine, norepi, I do want you to know the difference between alpha 1, alpha 2, beta 1, beta 2. Those are the big things we're going to be noting there. Okay. So as far as like knowing delineations of different receptor types, that's the level I want you to know. Okay. Which makes sense. We've already talked about many of these all throughout the course, so this should just be a review for a lot of us as we get to those points there, right? Typically, you're going to find that most of the alpha and beta receptors are going to be G protein linked. Oftentimes, they're not going to be. Often, they're not ion-gated channels, anything like that. But definitely G proteins here. Now, looking at the effects between the two neurotransmitters, either epinephrine and norepi. Typically, what you're going to find with norepi, it has a lot more alpha effects has some beta effects, but typically you're going to find it's more predominantly has a higher affinity for the alpha receptors than it does the beta. Okay, and then with the epinephrine, typically it's going to be pretty balanced between alpha and beta effects. Okay, now clinically, that actually does come up every once in a while. So for instance, if I have a patient who is, say, coming to the ICU, they're critically ill, they're septic, they're hypotensive, the choice of what sort of vasopressor I want to use, whether I typically will give them epinephrine or norepinephrine, the recommendation I make to the providers is going to be based on things like what's their heart rate doing, what's their blood pressure doing, what is their volume status like. We make decisions based on these different effects here to say, well, do I want more alpha? Or do I want more of a sort of balanced effect? Or do I just want beta? There's different drugs that will do just that. So again, this will come up clinically depending on kind of where you're working and what you're doing, right? So let's look at the kind of overall alpha versus beta effects with the sympathetic nervous system. Typically with alpha receptors, you're going to think things like vasoconstriction, okay? So with blood pressure, typically things it's going to do, cause? Increases in blood pressure, right? Hypertension, I think, with alpha effects, right? We'll talk about alpha 1 versus alpha 2 in just a little bit, but mainly when we're talking about these effects here, we're thinking alpha 1 for the most part, right? We'll talk about where alpha 2 is going to be important in just a second, but other things you're going to expect to see. You're going to see iris dilation, which is otherwise known as mydriasis, right? So you're going to expect them to come with these big saucer-like pupils. Has anyone ever seen the movie Requiem for a Dream? The scenes where they actually do drugs and then you see their pupils either like shrink or dilate. Usually it's pretty good about actually being real to life, where to say, okay, well, they just did a whole bunch of cocaine, pupils are getting very large, right? And all of that goes back to the alpha effects we're going to see there, right? Typically you're going to see more intestinal relaxation with the alpha effects, because remember, when you're a fight or flight sort of response, do we really care about GI function at that point? Not typically. So typically you're going to find the GI tract is going to be more inhibited by these effects here as well. Because remember, one of the main things we're seeing with the sympathetic effects, and primarily the alpha receptors, is shunting blood flow from areas where we don't really need it at that time to areas where we do need it. So for instance, we probably don't need it in a fight or flight response to going to the GI tract. However, the skeletal muscle, absolutely, right? If we're trying to run away from whatever that aggressor happens to be. Other things you're going to expect to see, things like intestinal sphincter contraction. That makes sense because, again, we don't want necessarily a lot of flow, say, from our stomach to the small intestine to the colon. Like, we don't need that to be, we don't need that function going on right there. You can see things like pilomotor contraction, right? So you may see like goose pimples and things like that develop. Typically, bladder sphincter contraction. Remember the alpha effects there on that internal urethral sphincter. Remember that, because again, we want to keep our blood volume up, so we don't necessarily want to release a lot of urine there. And then the main thing you're going to see with alpha 2 effects, here, remember we talked about autoreceptors? We talked about there's receptors that lie on the presynaptic neuron that actually, when it gets activated, shows that, hey, we have enough transmission happening here, we can shut down further release of these neurotransmitters. Remember what I'm talking about? Let me do a quick drawing here. Again, my drawings are terrible, but let's imagine we have our presynaptic neuron and we're going to have our postsynaptic neuron here. Remember, the autoreceptors are going to lie basically off to the side, and when there's enough neurotransmitter floating around, it will then feed back here, and then we'll shut down further release from that synapse, or from that neuron, okay? So again, this is good for shutting things down. Again, when you think about things being sympathomimetic, those are things that are going to be stimulating or mimicking the sympathetic nervous system. When you have something shutting down the sympathetic nervous system, we call that a anyone know? It's called sympatholytic. So we ever hear that term, that's basically what we're talking about, shutting down the sympathetic nervous system. We can do that with alpha 2 receptors. So basically, if I gave something to stimulate alpha 2, that would shut down further sympathetic release, and you would see things like drops in blood pressure, you see things like drops in heart rate, etc. Right? So that's good for things like controlled blood pressure, lots of other disease states. Anyone ever heard of the drug clonidine? That's a big one that will do that as an alpha 2 receptor. We'll talk more about that when we get to talking about hypertension, etc. Next semester. On the flip side, talking about beta receptor function, typically we say with beta receptors, you're thinking of beta 1 and beta 2. There's also beta 3, but it's not really as important for our purposes here. Some people believe it helps with things like thermogenesis and lipolysis and whatnot, but predominantly we're thinking beta 1 receptors. You think about what organ? Think about the heart, right? What does it do there?
Contractility.
Stimulates contractility also. Chronotropy also stimulates the heart rate as well, right? So those are big effects for beta 1 receptors. It's the biggest thing you're going to see with that. Most of the other effects you're going to see throughout the body are going to be predominantly beta 2 effects. And we said with beta 2 effects, especially on smooth muscle, you typically see relaxation or constriction. Typically relaxation, right? So again, you think beta 2 effects, you typically think relaxation. So you can see that here, right? So for instance, if you think of vasodilation, you're going to find that typically Beta 2 effects are going to cause a little bit of vasodilation. This is good because when we're in a fight or flight response, maybe we can constrict blood flow, say, to the GI tract. However, we can actually vasodilate and allow more blood flow to go to the skeletal muscle, right? We're shunting blood flow from where we don't need it to where we do need it. And so you need to have sort of a balanced effect of causing vasodilation versus constriction, as the case may be, right? Overall, if I were to give, say, a non-selective sort of agonist at both alpha and beta receptors, typically you'd find that you develop hypertension overall. So typically the alpha effects are going to more stimulate, be a little bit more predominant there. But if I were to give just specifically a beta 2 agonist, you end up seeing dilation of those blood vessels, see a drop in blood pressure. Other things we see intestinal relaxation, right? That makes sense because, again, we don't necessarily want digestion to be occurring here in a fight or flight response. We see things like uterine relaxation. In fact, one of the things we can give to patients who may be undergoing premature labor, we can actually give them a beta 2 agonist that will relax that uterine muscle to hopefully stop those contractions from occurring. That's one thing we can do, right? Bronchodilation, this is huge for what disease state? Asthma, right? So when we talk about asthma, and again, a lot of patients that develop asthma or have reactive airway disease, you're going to find this is very important because this will cause bronchodilation, right? It's going to relax those bronchial smooth muscles and allow for better airflow. Those are the big ones. Other things, though, we can see things like glycogenolysis. Why is this important in a fight or flight response? Yeah, we're going to drive up our blood sugar, right? We want to get more energy going to the skeletal muscle, so that's how we do that. And glycogenolysis typically occurs in what organ? Predominantly. Right in the liver, right? Because that's where we're going to be storing a lot of glycogens. We're going to break that down and try to raise up our blood sugar levels, right? Okay, things like bladder wall relaxation, we already kind of talked about that. And again, that makes sense because these need to work in concert with one another. So if I'm in a fight or flight response, I don't want to urinate, I don't want to have micturition, I'm going to have beta effects relaxing the muscle in the bladder, detrusor muscle, and then I'm going to have alpha effects causing constriction of that internal urethral sphincter, right? And all this stuff kind of comes back, so don't shove everything away, right? You want to transfer, you want to help to facilitate those memories from the intermediate storage to long-term storage, right? So I keep repeating things over and over and over again, right? Goes back, yes?
For the alpha receptor, it seems like everything is like constriction, contraction, except for the intestinal relaxation. Is it just because it's less of the alpha receptor being activated there in the intestine, or is it like actually causing relaxation?
It's probably more so to do with things like blood flow, right? So again, if you're kind of shunting blood flow away from the GI tract, it's probably not going to be as like stimulatory, right? You're just not really getting as much activity. It's more of a minor effect than you would see with, like, say, the beta effects, I would say, in that case. And typically what you're going to find is that, say, for instance, with things like blood pressure, like sympathetic has like a ton of effects, muscarinic maybe not so much, right? From this standpoint, from the GI tract, sympathetic has some effects, but not as nearly as much as the parasympathetic. So you're going to find that in some organ systems, you're going to have a lot bigger balance towards one autonomic nervous system versus another, as the case may be. So here it's going to be generally inhibitory, though, by not causing active constriction of the muscles there. Yeah. Because you do see like things like intestinal relaxation, but you have the sphincters actually contracting, right? So again, it seems counterintuitive, but in the end, it ends up working out. Okay, so looking at the eyes, let's look at some of the autonomic effects you can see here. So again, I'm not going to get super granular and talking about M2 versus M3, but just know what I'm saying. And I'm talking about the muscarinic receptors. We're talking about these M receptors. That's just all that means there, right? So typically what you would expect to see with the eye, you can see things like with the radial muscle, right? We're going to expect to see contraction here causing my dry. So remember the radial muscles, those are pulling the iris out. What did the opposite effect? Remember, the circular muscle would contract, and that would be caused by things like acetylcholine, right? So that would be acetylcholine muscarinic receptors. You expect to see contraction, and you see meiosis, right? So again, you expect to see that sort of picture there with someone who had too much acetylcholine sort of effect. So if you had to imagine that you were working with an ophthalmologist and you wanted to dilate someone's eyes, right? So you want to do say fundoscopic exam or something, you want to dilate the eyes. How could you do that? Based off of altering the autonomic nervous systems. So I want to dilate the eye, so I can either stimulate alpha-1 receptors, so I can get something to stimulate that to try to dilate the eye, or what's the other thing I could do? I can inhibit the muscarinic side of things, right? And actually, in some cases, we'll do both, right? So, for instance, we'll have something called, say, you don't have to know the drug name. I'm just kind of giving you clinical examples of how we do this. You'll have things like phenylephrine that will go and just bind to alpha-1, will cause dilation, and you can also have things like atropine. Some people may be familiar with the term or the drug atropine. That's an anti-muscarinic. It will block muscarinic receptors and actually will inhibit this contraction here, right? So there's two ways you can affect the system. You can either directly stimulate it or you can block it. And in these cases, you can actually stimulate one and block the opposite and actually cause synergistic sort of effects there. So in some cases, our ophthalmologists will use both to get really nice, wide dilated eyes so they can do what they need to do for either exams or procedures, whatever they have to do, right? That's one of the big ways you'll see that. And we do that in ER all the time, people coming in with injuries to the eye and whatnot.
Stimulate alpha-1 and block beta?
Not block beta, but you block the muscarinic receptors, yep. Yeah, so you could stimulate the sympathetic effects, but block the parasympathetic effects, right? The opposite could be true as well. Say, for instance, I could maybe block the sympathetic effects and then stimulate the parasympathetic, and that would cause what? That would cause more constriction, right? So again, the radial muscles would relax, but the circular muscles would constrict, and I expect to see meiosis that could develop there, right? So again, you can monkey with the system in a large number of ways. Again, sometimes we're doing this, say, intentionally. So if you're working with the ophthalmologist, you do this intentionally. However, a lot of times patients are doing this themselves when they're trying to get, say, for instance, try to get high off cocaine. You know, this is typically something that's very stimulatory on the sympathetic nervous system. So when the patients come in, one of the things that I look for these big saucer-looking pupils. If I see that, that gives me a sign that, hey, they're having a lot of stimulation here. They're either having a blockade of the muscarinic effects or they're having stimulation of the sympathetic effects. That's one piece of the puzzle there. And then if I see a bunch of powder on their nose and they're hypertensive and tachycardia, okay, probably cocaine, right? I can probably link it back to say that is what we're talking about here. That's what the patient's experiencing. Though this is just a little bits of clues that we can use to try to piece together a picture to say, well, what's going on with the patient here in these cases, right? Yes?
Does one effect last longer than the other, like constriction versus, or blocking versus stimulation?
It depends all on what you're using. So in some cases you can find that things will stick around for a good period of time. Things may not stick around for as long. It just depends on the half-life of the drug in some cases. Other things you're going to find as well is that typically, remember that accommodation is also affected. Actual accommodation of the lens can be affected by affecting these systems additionally. And so that's why, for instance, if the ophthalmologist, say, for instance, or the optometrist, whoever is doing the eye dilation, if they used an alpha agonist, typically you can still accommodate pretty well. So even though they dilate your eyes, you're still able to you won't have as blurry a vision. You can still maybe go out and drive afterwards. Versus if they use an anticholinergic, something like an atropine, that typically affects accommodation. You have very blurry vision. That's why you need someone to like drive you home from the office and things like that. So sometimes it can depend on other factors. But the duration is all going to depend on how long the drug's sticking around potentially. Yeah. Okay. Other things you can expect to see. Typically, remember we talked about dumbbells as being a mnemonic for what? Parasympathetic, more specifically, muscarinic effects, right? We're going to delineate that in just a few minutes here, but muscarinic effects is the big thing. We're going to find that typically it's going to be stimulating secretion of glands and things like that. So again, lacrimation is going to be a big thing that gets stimulated here. So if I had a parasympathetic acting agent on the muscarinic receptors, you expect to see secretion. And again, you don't have to know all these pluses if one has 2 or 3, but this kind of gives you an idea of basically the gradation of effect here. So again, this is going to have a much more strong effect than you may see here in the lacrimation glands with the sympathetic effect. This is the big one here where you're actually going to see a lot of secretion to have a lot of tearing. On the flip side of this, though, if I were to block these receptors, what do you think would happen to the eyes from a lacrimation standpoint? You can play a dry eye, right? So again, that could be pretty, bothersome to the patient. They may end up developing things like corneal abrasions because of that. So that could be another side effect you see is if they ever complain like really dry eyes and a hard time seeing. That could be related to anti-muscarinic effects. That's actually a big thing you see with a lot of patients who go on cruises. Oftentimes, everyone ever heard of like a transderm scope or a scopolamine patch? They'll put that on. It's a strong anticholinergic drug, and they'll put it on a couple of days before they go into a cruise because, as you know, the vestibular apparatus, oftentimes if you're on something that's like constantly moving like this, like your equilibrium is going to all be thrown off, and it can cause a lot of nausea and vomiting. So they'll use anti-muscarinic drug to actually block that. And so one of the big things that we'll complain about while they're on the cruise is they can't really see all that well. Maybe some blurry vision, dry eyes, another big one, right? That we kind of be dried out all over, in the case may be. Anyway. All right, looking at the heart. There's a lot of effects here on the heart, but it's important to kind of delineate the effects here between sympathetic versus the parasympathetic here, right? So typically, when you're looking at things like the slow response cells, the ones that the pacemaker-like cells, we're talking about things like the SA node and the AV node. What do you see when you have, say, beta 1 stimulation? Increase in heart rate, right? Good. So if I'm stimulating the pacemaker cells, I'm going to stimulate the actual heart rate itself. And again, if you go back and talk about our cardio lectures, remember this had to do with affecting things like potassium efflux, right? By causing, say, blocking potassium efflux, you cause the cell to be more positive, and that cause the actual potential to be easier to reach, right? Those are those cases where you can modify things either by changing how much ions are coming in, or by affecting how much is leaving, you can affect things like automaticity of the heart and actually increase it, as the case may be. Now, there's probably some beta 2 effects here, but this is not predominant. Beta 1 is the main thing that's going to be stimulating the myocardial tissue here, okay? So there's that, and then with the atria and, say, the ventricles, what do you expect to see? Contractility is a big thing, right? So again, we're expecting to see a stronger squeeze. We can do things like increase our cardiac output by stimulating not only the speed of the heart with the pacemaker cells, but also stimulate the actual contraction of the heart muscle itself by stimulating these beta 1 receptors. Now, you'll also notice that sometimes, you can have these idioventricular pacemakers. These are things where if you overstimulate these receptors, potentially you can cause what? An arrhythmia, basically, right? So again, if you stimulate automaticity in tissue that normally should not be causing automaticity, right? If you're not usually, if you have some kind of ectopic pacemaker or something that can be stimulated by these beta 1 receptors, this is where potentially you can see an actual arrhythmia occur because of this. Okay, so again, all things with moderation, as you'll see. But if I overstimulate this, say I give someone epinephrine, a potential side effect could be develop an arrhythmia, right? VTach, VFib, something like that. Above and beyond the typical tachycardia that you would see with the stimulation. Okay. On the other side, typically with parasympathetic effects, you're going to find that predominantly what effects are we looking at? Or to give you something that stimulated muscarinic receptors on the heart, it's predominantly going to affect contractility or heart rate. Heart rate specifically, right? Really, you don't find a ton of effect on contractility. If it is very minimal, right? So typically, if you have, say, something like stimulating muscarinic receptors, you'd expect to see bradycardia. Yeah, you see bradycardia. Perfect, good. Versus if I were to get something, say, were to block the muscarinic receptors, you'd expect to see what? Tachycardia, right? So the same drug I talked about, atropine, you can use it in the eye to cause dilation. I can also use it in the body more systemically to actually cause tachycardia, and that's something we will give when you do ACLS and PALS next summer, I should say. You're going to run into that. It's one of the drugs that we use potentially for someone who's bradycardic. We will give them atropine to block the muscarinic receptors to try to alleviate that parasympathetic tone to try to increase the heart rate. That's one of the ways we can do that. Again, the other drug I mentioned, epinephrine, you can actually give exogenous epinephrine to the patient, and that will also stimulate the heart tissue as well. Okay, so I can either block something or I can stimulate it to get very kind of opposite effects. Okay. For the blood vessels, typically what you're going to find is that the parasympathetic, not a lot of innervation here. Not going to see a ton of effects in regards to parasympathetic activity here. The big one we're going to note, though, is going to be sympathetic effects. Okay, the big delineation here is going to be that typically with alpha 1 receptors being activated, you're going to see constriction or dilation. Constriction. Alpha 1, you want to think constriction. Okay, with beta 2, you typically want to think dilation. Okay, so if I have beta 2 effects, I'm stimulating beta 2, I'm going to expect to see dilation. If I stimulate alpha 1, I'm expecting to see constriction. And again, this is important that it's balanced appropriately, so that way if I'm in a fight or flight response, I can shuttle blood to, say, the skeletal muscle, the heart, the brain, but I can maybe take it away from places like the gut, or maybe, for instance, the kidneys, or wherever else. It doesn't really need to go at that time to make sure I keep blood volume up, to make sure I keep all those organs I need to be perfused, adequately perfused, as the case may be. So again, this primary thing, typically think constriction. Again, look at this. Look at, say, constriction here with the coronary vessels. Is that a good thing or a bad thing? Could it be a bad thing? What happens if I had too much constriction of the coronary vessels? You decrease the amount of oxygen delivering to the heart that causes myocardial ischemia, which can lead to an infarct or actually killing off that tissue. And that's why one of the big things we'd see, especially if you work in a more like downtown sort of setting, kind of a more urban sort of setting, there's a lot of cocaine use. And one of the big things causing people to come to the ER is, guess what? Cocaine chest pain. Huge thing. We have so many patients that would come in for cocaine chest pain because you have so much alpha constriction of those coronary vessels. They come in complaining all this chest pain because they're not delivering enough oxygen to the heart. And then you have to rule out, okay, well, do they actually induce a STEMI, or is this just something where I can just let the drug wear off and they're back to normal? A lot of times these patients, they have pristine hearts to begin with. I mean, they've made some interesting life choices to get to the point where they're doing cocaine. So maybe they have not made good life choices elsewhere. So oftentimes they have coronary heart disease on top of the fact they're doing cocaine as well. So again, you can see a lot of cocaine-induced MIs, things like that, because of that constriction there. Okay. So anyway, very important things to consider. So you can just typically think constriction is going to be the main thing with alpha effects. Beta 2 is going to be more dilation, which makes sense. Okay. Looking at the lungs, so again, we're going to find the muscarinic receptors are going to be playing a big role here, along with the adrenergic receptors. So again, when you're thinking about things like the tracheal and bronchial smooth muscle, typically beta-2 effects, you're going to see relaxation, which makes sense. It drives with what we already know. Beta-2 effects typically cause smooth muscle relaxation. So if I have someone who's having an asthma attack, say for instance, you put a cat in front of my face, all of a sudden my bronchial smooth muscles are going to start to constrict. Again, don't use that as a weakness against me one day. But you start to see my bronchial smooth muscles start to constrict and probably start to wheeze because I'm not able to move air very well. And in order to combat that, my body's going to start to secrete epinephrine, norepi onto those beta-2 receptors and hopefully cause some smooth muscle relaxation. Or if I were to use my inhaler, that's a beta-2 agonist, that would then cause relaxation in that muscle as well. Okay. Other things you can see with the muscarinic receptors, typically this is going to cause more contraction of that smooth muscle. Yes, sir.
It's for the last slide.
Sure.
You're saying coronary constriction happens when the sympathetic nervous system is activated.
Typically for like alpha effects.
Why wouldn't you have dilation of the coronary heart blood vessels to increase blood flow to the heart?
So there's other systems at play as well. So for instance, you have things like endogenous, like nitric oxide pathways that we know that can be vasodilatory as well. So typically with like an appropriate sort of like fight or flight response, like you will find that you can still deliver enough oxygen to the coronary tissue. But again, sometimes by increasing that pressure, you're able to get kind of blood flow going predominantly to the areas you need it to, but in those cases there, when you have an overbalance, right? So for instance, you have someone who maybe already has some narrowing of the vessels because they have atherosclerosis, or for instance, they have too much stimulation where they take cocaine or methamphetamines or something like that. That's when you can have that overbalance and you have way too much constriction, and that's where you can see deprivation of oxygen being delivered to the heart, right? But typically, in normal healthy individuals, we have a good balance. Or even though it does cause constriction, it's not enough to really cause things like chest pain due to ischemia, basically. Okay, as for the parasympathetic effects, as I mentioned, this is actually one way we can diagnose asthma. We will actually give them something to stimulate this, and they cause smooth muscle constriction. Then we know, okay, yes, they are hypersensitive to this. They have reactive airway disease, and we can then reverse that. But that's one way we can actually know that. The other things you're going to see, this is the big effects here, is actually when you have overstimulation of muscarinic receptors, you'll see a lot of bronchial gland stimulation. You're going to be secreting a lot of fluids into the lungs. Okay, and in fact, one way we can actually do this, if we have a patient. We do this all the time, especially for a lot of our kids who are like chronically intubated, or if they're like trach patients or something, and they have a lot of airway secretions as a result of that. Oftentimes we're giving them things to actually block muscarinic receptors and try to dry them out, actually dry up a lot of those secretions. That way they can aerate a little bit better, they can move the oxygen and oxygenate the blood a little bit more easily, as the case may be. So again, it's one of those things where if you were to inhibit muscarinic effects in the lungs, you'd expect to see the lungs dry out. If I were to stimulate it, you expect to see a lot of bronchorrhea, right? A lot of mucus secretions and things like that in the lungs.
So what type of drugs would you give for like cystic fibrosis, stuff that would block these glands from...
Cystic fibrosis is a little tough because it's not necessarily that their secretions are more copious than you would see with like an individual without cystic fibrosis. The problem is their mucus is so tenacious. Not tenacious like it's going to go out and get that job, but like tenacious and like it is very thick and viscous and not moving, right? So the stuff that's there, they can't clear very well, because remember what's lining the airways to try to move stuff out? All the cilia, they can't really pump against all that really kind of thick, nasty sort of mucus there. So oftentimes what we give are things called mucolytics. They're going to be things that will try to break up the mucus so that way they can clear it a little bit easier. And so they oftentimes will have things like hypertonic saline, so very concentrated saline that can help to try to get that a little bit more, draw some water into it. We'll do things like DNA. Actually, we have drugs called DNase, which is actually a DNA an enzyme to break down DNA, so it can actually break down some of that DNA there and actually help to break it up, and different things like that. And then we'll do what we call chest physiotherapy. So they'll have things like vessel put on that will actually kind of percuss them in order to break up that stuff, so that way they can cough it up and get rid of it, or they may just do physical percussion of the patient itself. So yeah, so rarely do I see we're actually using anticholinergics to dry them out, because again, oftentimes the problem is their mucus secretions are so dry anyway that it would just worsen things. Yeah, that's a unique point. But we'll talk about CF and PEDS probably in the winter semester. Okay. Anyhow. Okay. Any questions from the first half? I just love the power of a good shush. Anyway, it's like half the benefit of being a teacher is I can shush people and they automatically just like quiet and go like the DMV or anywhere. I just do it and they just shush up. Doesn't work that way. Any questions from the first half? So again, there's a lot of details on these slides here. Focus like on the big picture sort of things. Look for the kind of the big sort of trends you're seeing with things like, okay, beta 2 causes smooth muscle relaxation, alpha 1 causes constriction. If I spend 10 minutes talking about something on here, it's probably more important. It's probably something I find to be more important that I may be more likely to perhaps maybe write a test question on. So again, if I gloss over something on the slide, like, yeah, you can memorize that, but you may not get as much utility as memorizing something that I spend a lot of time on, okay? Because again, you have a limited amount of time, and I want you to use it wisely. So anyway, all this stuff is important though, so memorize it all. But if you had to spend time memorizing anything, at least what I'm talking about a lot is important. Anywho, so going on to the stomach functions here. So again, typically you're going to find a lot of parasympathetic activation of the smooth muscle, or the gastrointestinal tract. Typically, you're going to see a lot of increase in motility and tone when you see muscarinic activation here, right? So again, if I were to take some, and again, it makes sense based off what we were talking about with, remember we were talking about the cephalic phase when you're actually like seeing like a big steak come along, like that's part of that vagal stimulation there, is to get things starting to move. Say, okay, let's start some salivation. Let's go ahead and get that amylase cooking here. Let's go ahead and get some pepsin generating, all of that. A lot of it going through the parasympathetic activation there, which makes sense. Typically, you're going to find some relaxation here at the sphincters, and again, you'll find the opposite when you get into the sympathetic effects here. Typically, decreased motility and tone. We don't need to digest stuff if we're in a fight or flight response. Typically, you're going to contract the sphincters. Typically, you don't need a whole lot of secretions here. However, you can find that there still can be issues. So, for instance, imagine you have a patient. If you go back to the GI lectures there, remember that stomach acid is usually a pH of what? 2, right? And so we want to keep that stomach acid. Can it tell the difference between hamburger or the GI lining? They can't tell the difference, right? So again, what protects our stomach from being digested by itself? The mucus barrier, right? So again, what do you remember stimulates that mucus barrier? Prostaglandins, and what else? Acetylcholine, right? And there's muscarinic receptors as well that also stimulate that mucosal barrier. So one of the things you run into though is you can actually find though that say for instance you would have say too much cortisol around. Say you're in a very stressed sort of situation. Say you get an illness or something. You can still have sympathetic innervation. Say of like the adrenal glands going to increase levels of cortisol. Remember what cortisol does to inflammation? Inhibit it or stimulate it? Typically, actually, it's actually inhibitory, right? So again, typically you're going to find that glucocorticoids are going to try to inhibit things like inflammation. But also one of the things that will inhibit is production of prostaglandins, right? So it will inhibit production of prostaglandins. So what does that do to the stomach lining or to the stomach mucosal barrier? It can actually reduce it. So I can have patients that are in a very chronic sort of fight or flight sort of sympathetic response that actually have degradation of that mucosal barrier, and then I can now have that pepsin start to digest the stomach, and then you can have things like stress ulcers that can develop there, right? So again, if you imagine, you guys probably may develop some stress ulcers while you're actually here in school, right? Because your glucocorticoid levels are going to be skyrocketing over the course of the next 2 years, right? Like I said, I wish I could do a study where I could like see your levels like at day 1 and track it all the way through, and then like when you get to rotations, it kind of drops off a little bit, and then right before the pants will pick back up again, and Anyway, so you can sometimes see some other sort of other systemic effects that kind of feedback and can interact with some of these systems here. So again, it gets a little bit more complicated, but in general, broad strokes, typically muscarinic effects are going to stimulate the GI tract. Typically, adrenergic effects are going to inhibit it. Yes, sir.
So with the alpha 1 receptors, you're contracting the sphincters so food doesn't get there, and I guess you're not really digesting things?
Yeah. So for instance, if I were to say constrict the pyloric sphincter, right? What is that going to do? Yeah, prevent food from going from the stomach into the small intestine. So again, by inhibiting that motility, by keeping things from going from one area to the next, you can inhibit that actual digestion from occurring. That's one of the big things you'll see with that. Yep. Looking at the intestines more specifically, you can find that typically sympathetic effects are going to decrease motility and tone, as we mentioned, decrease secretions, and then with the parasympathetic effects only going to be stimulating secretions, stimulating contraction of things like the gallbladder, actually cause release of bile. And again, some of this can be a little bit more kind of counterintuitive because you think muscarinic, don't necessarily think about stimulating things like smooth muscle, but here you actually see contraction there, right? Versus with the relaxation can happen here with the beta 2 receptors, so that way you can hold on to that bile because we don't need to digest things in a fight or flight sort of response. So again, typically beta 2 inhibiting that smooth muscle contraction. Urinary tract, we talked about this quite a bit. Typically the sympathetic effects is going to do what to our kidneys? Shut them down? Yeah, to a certain degree, right? So again, we talked about things like the afferent arterial, right? So what happens when norepinephrine interacts with the afferent arterial? It's going to constrict it, right? So it's going to decrease GFR in those cases. It can also stimulate some renin release, as the case may be. This is actually more of a kind of a beta-1 effect there. And in other cases, you may actually find that alpha-1 stimulation will decrease renin release, as the case may be. And so that kind of makes sense because, again, renin is typically released as a result of what? So it could be as a result of low blood pressure, but what's the direct stimulation of renin release? What are the kidneys detecting? Yeah, low sodium, low volume there of filtrate at the distal convoluted tubule, right? So again, it's one of those things where norepi is want to keep blood volume up. So renin, in essence, even though it stimulates the sympathetic nervous system in a roundabout way, it itself is trying to get renal blood flow up, right? It's trying to increase that GFR. So again, they're kind of, in some regards, diametrically opposed to one another, even though they're both being kind of stimulated by the same things, as the case may be. So again, just know that with alpha-1 stimulation, you may see a little bit of decrease in renal release, but the beta-1 effects here are going to outweigh that. So typically, you're going to find that the sympathetic activation will try to increase renal release, which is again going to help to stimulate the sympathetic nervous system even further and develop that things like hypertension and whatnot. Yes, sir.
You have beta-1 receptors on the kidney?
You will have some beta-1 receptors in the kidney, yes. Which is why if I give someone like a beta blocker, for instance, that's one of the drugs we may use like for hypertension, you can actually end up seeing some decrease in renin activity there, which can help with that additionally, right?
You said it's mainly on the heart though, right?
Beta-1 effects are predominantly on the heart. So again, if you had to memorize anything from the effects of beta-1, like the heart stuff is way more important for our purposes than for the kidney stuff in this case. Yes, sir?
Just trying to understand what you said. So with alpha-1, alpha-1 receptors from the body is affecting, sympathetic is affecting alpha-1, and that's going to drop blood volume, and the kidneys release renin to try to compensate for that and increase GFR?
Yeah, so the alpha-1 effects would decrease. So in some cases, it may have a little bit of decrease in renal release, but more importantly, it's going to constrict that afferent arterial, right, which decreases GFR, which then the kidneys detect that decrease in GFR and say, well, let's increase more renal release, right? And that tries to increase GFR by closing down the efferent arterial. It tries to ramp up the sympathetic nervous system, tries to have ADH increase in release. So you can see how this is sort of a cyclical sort of effect here that occurs, which is why it's so important that whenever you have, like, say, you're treating someone for hypertension and you interrupt one of these systems here, you're going to find that the other systems typically try to compensate for that, and that will actually limit how effective some of your therapies can be here, which is sometimes why you need synergism and you need to get multiple drugs attacking different pathways in order to get better effects, essentially, right? Looking at the bladder here, you're going to find that typically detrusor is going to cause more relaxation with beta effects. It's going to be stimulated by the muscarinic effects. We've gone over this previously, so you guys are pretty familiar with this. Remember, with the actual sphincter tone itself, contraction is going to be more related to alpha-1 effects versus relaxation is going to be with the muscarinic effects. Okay. And as far as motility tone, this is going to be less important because, again, most of this is going to be maintained through the bladder. It's going to be controlled through there. All right. Looking at uterus effects, you can see with, say, a pregnant female, you may actually find that you can have contractions stimulated by things like the alpha-1 receptors, but typically beta-2 is going to cause relaxation, which is good if you have someone who is, say, premature contractions, premature labor. You can actually help to inhibit that by giving like a beta-2 agonist. Also, alpha is going to be really important for things like ejaculation. Again, remember, there's always going to be some tone from both parasympathetic and sympathetic going at all times. It's just a matter of which one's kind of more in taking the lead there. But again, remember that with muscarinic, you need to have the effects here to cause an erection, and then you have to have the alpha effects in order to cause ejaculation. If you're missing one or the other, then you may not be able to actually achieve that. And then you can have things like erectile dysfunction, things like that, for a male might be come to you to get treated for. Okay. Yes, sir.
You said norepi would decrease GFR, right? Just to clarify.
As a direct effect on that afferent arterial, yes, you would see a decrease in GFR. Yep. Okay. All right. Looking at the skin, typically you're going to find the alpha receptors are good for causing contraction of both the piloerector muscle, so you can typically see your hairs raise up, and then typically you're going to see a little bit some sweating associated with that. You're going to find a stronger effect from the muscarinic receptors here, though, as far as causing secretions from the sweat glands. If you ever have someone who is having kind of overactive muscarinic effect, you're going to see a ton of sweating. Again, we talked about secretions kind of coming from everywhere, but a lot of sweating is going to be involved with that as well. And then some other miscellaneous effects here. So for instance, things like, the beta-2 receptors. Here you can actually find increased contractility. That's why when you have, say, if I were to call on one of you to come up here and explain this chart, you'd probably be a little jittery, right? You probably have, some shaking going on. A lot of it has to do with those beta-2 effects. And so that's why if I were to, say, give someone, say, a beta blocker, some people who use that for performance anxiety, it helps to decrease some of that contractility. It actually helps to decrease some of those jitters you get. So for instance, if you needed to perform, say, as a musician, you play the saxophone, say for instance, you need to make sure you have very fine muscle control. If you're sitting there having tremor, you may not be able to finger the right notes, and it may sound bad. But if I were to block those effects, and you end up seeing that decrease in contractility, right? So that helps out quite a bit there. From the liver effects, you typically are going to see alpha and beta are going to be helping to stimulate glycogenolysis and gluconeogenesis. This makes sense based on what we've talked about previously. Pancreas effects aren't going to be quite as important here. However, if you're looking at, say, for instance, say like on the beta cells, what happens with the beta cells? What do they release? Insulin, right? So in some cases, you may find that beta-2 can actually stimulate secretion of insulin. Doesn't sound kind of counterintuitive, though. We just said the beta effects here are trying to stimulate glycogenolysis and gluconeogenesis. Why would that work together? Yeah, so how does that glucose get into things like the skeletal muscle? Well, you got to have insulin there, right? So you have to have insulin to actually drive those glucose transporters to be taken up to the cell surface to actually allow for that to be imported into the cells. Again, that's a big problem with diabetic ketoacidosis. They have an insulin deficiency. They can't drive that glucose into their cells to actually utilize it for energy production. That's why they end up developing ketosis, because they need an alternative energy source, right? That's why they get acidotic like that. Fat cells, you typically find the sympathetic nervous system will start to induce lipolysis. That makes sense because you want to break down fats for more energy there to form ATP. And then salivary glands, typically you're going to expect to see a lot of secretion due to the muscarinic effects here. A little bit with the alpha, but typically the muscarinic is going to be the stronger effects on the salivary glands. Okay. So that makes sense. Again, kind of go through the chart, kind of know the general effects. So if I had someone who was in a much more sort of sympathetic sort of effect, sympathetic sort of tone, what would you expect to see? What would you expect their blood pressure to do? What would you expect their heart rate to do? What would you expect their sweat glands to do? Things like that. You'll get a general picture of what those patients kind of look like. So that way when someone comes in and they're diaphoretic and they're tachycardic and they're hypertensive and their pupils are dilated, you can say this looks like a sympathetic sort of patient. Maybe it's due to pheochromocytoma. Maybe it's due to thyroid storm. Maybe it's due to cocaine. And you come up with a differential based on what they're showing you, and a lot of times the autonomic signs and symptoms can give you a big clue into that, right? Now going to the mnemonics, we talked about dumbbells already as being our muscarinic mnemonic here, right? So again, remember that this basically is all the different secretions you're going to be stimulating when you have stimulation of the muscarinic nervous system here, or muscarinic receptors, I should say. So defecation, urination, meiosis. Remember the killer bees, these are the things that are going to be potentially deadly for your patient. So again, if they have bradycardia, they're not able to perfuse very well, that could be a problem, right? Bronchorrhea, right? Their lungs are filling up with fluids, they're not going to be able to oxygenate very well, it's bad. Bronchospasm as well. Emesis, lacrimation, and salivation. Okay, so those are the muscarinic effects. Now we haven't really talked about it, but there's nicotinic effects you can see here as well. So imagine you had, say, someone, and again, what's a popular way to consume nicotine nowadays? Vaping. Anyone do any vaping? Anyone have a sweet vaping rig by any chance? Neither do I. But you may come across patients who are either using it as an alternative. Actually, I don't vape. That's not really my style. But anywho, you're going to find that this has actually it's a big concern for me as a toxicologist, because some of these liquids that they're actually using to fill up their e-cigarettes or vapes or whatever, you end up finding they are very concentrated, full of nicotine. And if a kid gets into that, and again, it's not very well regulated. So if I go to any vape shop, I'm trying to think of any good vape shop names I've seen recently, because there's so many of them. Venom. Maybe go to Venom. I don't know if I'd want to get stuff from a place called Venom, or at least for personal use. I say Open Smoke. I see a lot of Up and Smokes out there. But so if I go to one of those places and because the regulations aren't really in place, a lot of those are not child resistant. And so again, kids who just open up, get a ton of nicotine. You will see nicotinic effects from that, right? Or if I have someone who has, say, for instance, a decrease in acetylcholinesterase activity, not only do you get these muscarinic effects, but you also see nicotinic effects as well. So it's good to know the mnemonic for the nicotinic effects additionally, right? And so I call these the days of the week, the effects you're going to see here. And this makes sense based on a lot of times the preganglionic synapses, right? Because again, if I stimulate the preganglionic fibers, do I only stimulate parasympathetic nervous system? No, we saw the effect sympathetic as well, so you can actually see some sympathetic effects from this because of that extra nicotine activity, the nicotinic receptor activity. So what do I expect to see the days of the week? I expect to see on Monday mydriasis. So again, you're stimulating those receptors. It can actually cause mydriasis, causes the pupils to dilate. You expect to see on Tuesday tachycardia. Kind of makes sense because if I stimulate those preganglionic fibers, I'm stimulating the sympathetic nervous system that causes beta 1 activation. It's going to cause increase in heart rate. It makes sense. You can see on Wednesday weakness. Now this actually goes back to our muscular function. So if you go back to the first PowerPoint slide for this section here, remember there's acetylcholine receptors that stimulate muscle contraction or nicotinic. Remember what I said, if you overstimulate them? You can see eventually they can wear out, they can desensitize, they can get tired out, and eventually what does that cause? Paralysis. It causes a flaccid paralysis there. So you can see weakness due to those nicotinic receptors being overstimulated, the muscles starting to get desensitized. You may not be able to generate the same kind of contractions you could, which eventually leads to paralysis. And when would that kill the patient? What muscle in particular? The diaphragm, right? So the diaphragm's not working, you're not going to be able to breathe, and that's no good, right? Now on Thursday, again, I have to make the mnemonic work however I can. We love mnemonics and talks, so we do this. But this is a bit of a stretch, but here we see hypertension. Again, that goes back to kind of stimulation of the preganglionic fibers stimulating the sympathetic nervous system, so you expect their blood pressure to be up. And then finally on Friday, you have fasciculations, and that goes back to initially when I stimulate those nicotinic receptors, what does that do to the muscle contraction? Yeah, I'll initially stimulate it, so you'll see some fasciculations, you'll see activation of the muscles, but then eventually that's when they wear out and you have the weakness and paralysis that develops there, okay? So again, this could either happen because maybe I have a decrease in acetylcholine esterase activity, or I have something that is stimulating too much nicotinic receptor activity, like if someone, like a little kid got into one of these vape cartridges, or they got into actual refill liquids or something. There's been some cases of kids getting very, very sick from this because they actually get into it and it's so concentrated, they get just even a mouthful and they get very, very ill from that. Other things you might actually find is that nicotine itself is very lipophilic. It likes to go through the skin very easily, which makes sense because when people are trying to quit smoking, what's way they can get their nicotine fix? With a patch, yeah, so that kind of makes sense. Yeah, there's actually been cases where they have, they call it like green tobacco workers illness or something like that, some name, where basically you'd have these migrant workers who were working in these tobacco fields and they were not wearing good PPE, didn't have gloves and long sleeve shirts and things like that on, so they're constantly in contact with these tobacco plants, getting all this nicotine seeping in through their skin, and they actually had some long-term neurologic complications from overstimulation of these nicotinic receptors, right? So sometimes you can see these things may be kind of more kind of gradual, kind of long-term sort of problems for these patients. But so that kind of makes sense between the muscarinic versus the nicotinic effects. So again, if I were to ask a question on the test and I would say, hey, what would be an effect of the nicotinic stimulation? You'd be able to delineate that from the, say if I said over muscarinic stimulation, okay, right? You should be able to do that, I would hope, based on this. Having a good mnemonic and you can bring it up during the test, get good recall, right? Transference to intermediate and then long-term memory, right? Keep it with you. Okay, some other autonomic considerations here. Again, I don't have a really good mnemonic for the sympathetic effects, but just think about kind of overstimulation. Think about the increase in heart rate. Think about the hypertension. Think about the mydriasis, decreased GI motility, decreased bladder activity. All those different things going to go into that sympathetic sort of picture there. Okay, so remember the autonomic fibers, they don't have to fire very frequently in order to maintain that function. So for instance, for skeletal fibers, in order to keep myself upright right now, a lot of those fibers need to get anywhere between say 50 to 500 say action potentials in a second just to stay functioning, right? Keep that tone up. With the autonomic fibers, maybe only 10 to 20 per second, so it's not very fast, but both of them have to maintain some activity. In all times, you're going to have some sympathetic activity and some parasympathetic activity. It's just a matter of kind of what balance they're going to be set in. They're always going to be active, and you can either increase the activity over what the baseline is, or you can decrease it under what the baseline is, but there's always going to be sort of a baseline set there, okay? And remember, there's lots of autonomic reflexes that can happen here. So imagine, things like, cardiovascular effects. Imagine if I were to say, like, bear down, like I'm trying to go to the bathroom, right? That would be stimulating which autonomic nervous system? I'm trying to stimulate defecation, which would be more parasympathetic, right? And then what effect is that going to have on the heart? It's going to slow it down, and then you can have vasovagal syncope, right? So you can actually have people pass out while they're pooping, right? Remember that Scrubs episode I mentioned a while back? That's actually what happens. You're bearing down, trying to defecate. You're stimulating parasympathetic nervous system that then feeds back, stimulates the muscarinic receptors in the heart, and then you have bradycardia, transiently, and they pass out. Okay, so things like that. Okay, so how do we control the autonomic nervous system? So you're going to find that the main functions here are going to be mediated through the hypothalamus and then also through the limbic system here, okay? Now remember, the hypothalamus is going to be that major regulatory center that's going to be controlling not only parts of the autonomic nervous system, but also the pituitary gland there. So things like, body temperature, things like hunger, thirst, all that's going to be helping to be regulated through there. And in the limbic system, you're also going to find some effects. This is going to be more autonomic responses to things like emotional states, right? Remember, we talked about the limbic system being important for a lot of different emotional responses. So imagine things like blushing, right? What's happening when you blush? Vasodilation, right? So again, if you think back to anyone that was there for the ping pong tournament, and Fadi, one of your upperclassmen, called out me and Professor Lack. If anyone saw Professor Lack's face, very, very red, right? That was an autonomic response to that, to being called out like that. All of a sudden, she gets very flushed, very hot, because of the vasodilation is being caused, and again, that was through the limbic system. So again, all that can be regulated through that, but again, more kind of like vegetative kind of regulatory functions get to more mediated through the hypothalamus, right? So again, if I'm getting hungry, I'm probably going to start to stimulate the parasympathetic nervous system to try to get the GI tract going, so that way when I eat something, it's going to help to digest that appropriately. Okay, so again, going back to ways that we can actually affect the system, right? So for instance, we can have things what we call sympathomimetics. That's basically things that are trying to mimic the effects of the sympathetic nervous system, right? So in some cases, they can be the direct agents that actually would stimulate it in the first place. So for instance, if I give someone norepinephrine through an IV, I can help to bring up their blood pressure. It's a common way we help to regulate blood pressure in, say, in a hypotensive patient, right? There are ways you can do that. There are ways to stimulate release of neurotransmitters, right? This can also stimulate the autonomic nervous system as well. So imagine I have someone who's on cocaine or amphetamines, that actually will stimulate vesicle release from those presynaptic neurons to actually release onto their target organs there. Okay, so that's one way we can do it. Otherwise, I can block adrenergic activity. So so maybe I want to decrease activity of the sympathetic nervous system. Maybe I get really anxious before I come up and talk to you guys, and so I need to decrease that activity. I can do things like block those receptors. That's one way to decrease activity from those autonomic nervous systems there, right? So things like beta blockers, right? Beta blockers can help to block the beta receptors. Maybe my heart rate goes down. Maybe I don't get that tremulousness that you would see with a fight or flight sort of response. Alpha blockers could do things like decrease my blood pressure, right? And clonidine mentioned it's an alpha-2 agonist, right? So actually they can have an alpha-2 agonist that would work up in the central nervous system there to actually decrease sympathetic outflow downstream, right? So that could also do similar things to decrease heart rate and blood pressure, etc. And then looking at ways to affect the cholinergic nervous system, the biggest things we can do here are going to be things like acetylcholinesterase inhibitors. That would do what to levels of acetylcholine? That would increase them, good. So you'd expect to see more muscarinic and nicotinic effects as well, right? So you can actually see both of those in those cases. And in fact, that's actually one way that we can try to wake up patients from surgery quicker. So one of the things that we'll actually do for surgery is we'll paralyze our patients, right? So we'll actually give them things that block all of those nicotinic receptors, okay? So I block nicotinic receptors. That means that neuromuscular junction now I have no transmission able to occur, right? Even though the CNS may be sending down signals to contract the muscle, those receptors are blocked up. It can't do anything, right? One of the ways that can actually work to wake up the patient faster and get their muscles working again, I can give them an acetylcholinesterase inhibitor that will increase levels of acetylcholine that will then kick those paralytics off the receptor, and then now I can have normal transmission again. That's something we'll frequently do in the recovery phase there. I can do things like block the receptors, things like antimuscarinic drugs, or I can actually stimulate the postganglionic fibers directly. This is where I can do things like nicotine, actually directly stimulate the fibers themselves. Okay. So again, just know there's different ways to affect the system. I can either affect the metabolism, I can affect the release, or I can affect the receptors themselves, and they can all have drastic effects on whether I'm trying to increase tone of the sympathetic or parasympathetic or decrease it. Okay. Any questions on that? This is the last slide of your physiology course. Congratulations. Let's do a quick 10-minute break, and we'll come back and do our Kahoot review.